All right. So our first presentation would be the digital public campaigns, and I'll be passing over the mic to the Ministry of Health team and the CHI team.
So just taking over from where Anthony has left us, for public health campaigns, I believe for everyone on the call, we have one or another been able to encounter some form of campaign. So specifically in the health domain, we know campaigns have been used for the long term to be able to reach out to all these disadvantaged communities who may be able to lack access to some of the routine services offered in our healthcare system. So specifically in Kenya, we know a couple of programs run a couple of campaigns in country. So for example, we know we have our Division of Malaria program, where we know within there are a couple of campaigns around the net distribution. There's a campaign around the seasonal malaria chemoprevention, targeting the children during the prevalent period for malaria. And of course, we have the IRS responsible for spraying. We also know around our disease surveillance program, together with the vaccine program, also run a couple of campaigns around polio, meningitis, and we know recently we all had a way of encountering the COVID vaccines, and also some measles rubella campaign. And we also know sometimes our nutrition program also normally do a couple of campaigns around vitamin A supplements, and we know this one sometimes is done together with the measles rubella campaign. And lastly, also we know one of another key programs is the division of neglected tropical diseases. And this I know is not familiar with many team members. With some of the diseases around trachoma, soil-transmitted helminths, or others known as intestinal worms, or other diseases like lymphatic filariasis, or commonly known as elephantiasis, or diseases like schistosomiasis, which is commonly known as bilharzia. So we know the couple of campaigns that are routinely being done in our communities, one or another, and we know all these campaigns are normally administered either through our community health workers, we are commonly known as the community health promoters in Kenya, or some of our healthcare workers in the case where you need to do some form of injectables, where you're giving, for example, things to do with the vaccines campaigns. So next slide. So when we got into the picture as Clinton Health Access Initiative back in 2020, mid-2022, we were funded by Gates to be able to come in and just try to implement our integrated campaign digitization. And by that, we essentially mean we have different campaigns running across the different programmatic areas. They are funded by different donors. They're targeting, in some cases, similar populations, and in some cases, different populations. So our idea was, can we come in and be able to see the different inefficiencies we see in these campaigns? For example, we know most of them, they're very fragmented. We know the issues around our population estimates, where how do we determine that we're actually getting the right persons for the campaigns and for the various interventions. We also know the challenges around resources, whereby we know for you to be able to deliver a campaign, because we know it's time bound, how then are you going to ensure that you can be able to reach the maximum coverage that you need to get in this time bound period? So when we got in, the work was one, how can we try to do a couple of things? And this thing is being done not only in Kenya, but in also 3 additional countries in Africa, where we have Nigeria, Benin, and DRC. So specifically for Kenya, one of our biggest asks was, can we be able to first do some form of demonstration of end-to-end digitization of campaigns? And I will get into the next slides to explain to the various teams what a campaign actually entails. And then 2, how can we be able to do some form of integration between 2 or more campaigns in terms of digitization? And then 3, which is so important, is again, how can we be able to ensure that these campaigns, which are normally done separate from your routine health systems, how can there be some form of integration with our routine health information systems? Because we do acknowledge we're in the digital era, and having technology can play a very big role in one, getting visibility on what is happening on the ground, and also to improve efficiencies in how we're running these campaigns in our resource limited settings. And more importantly, again, how can we be able to ensure that we have a government-owned initiative, so that even with the advent of Clinton Health, for example, not being in the space or being in the picture, can this initiative be able to still run on its own legs post any funding closure? And finally, also, since, as I mentioned, it's a cross-cutting exercise, what experiences can we learn from each other? What can we learn from Kenya? Can we learn from Nigeria? What can we learn from DRC? So that if there's any other country that actually wants to implement a similar thing, what will be the place where they can be able to get this information from, so they can be able to implement the same to avoid any replicating the wheel. Next. So for anyone who has not done any campaigns, a campaign is a very intense process where we know you have to go through a couple of things. One, you have to first of all determine what kind of campaign are you running. So I can give a very simple example. For example, we are running a campaign for neglected tropical diseases for bilharzia, for example. So a couple of things will inform how we need to do a campaign. We normally do a lot of prevalence surveys to just confirm what are the prevalence of this particular disease in this particular area that is endemic for this particular disease. So you have to map, do enumeration, understand in this area that you're going to do, what is the population, for example, who are the people we are going to be targeting, who are the people who will work with us, your healthcare workers. So there's a lot of planning that you need to do, what we're calling macro and micro planning. You have to do a bit of quantification because you need to know the population you're going to target, who are you going to work with that in terms of the healthcare workers. And then three, in terms of commodities, what commodities are you also going to be working with to ensure that you get the relevant commodities to be able to get to your persons. And more importantly, again, there has to be conversations around training, because for you to be able to actually administer this, the persons identified also have to be trained so they know what they need to do on the ground. And the training here encompasses two parts. There's the health talk, which you need to give as a healthcare worker to, for example, the person who's going to be receiving this intervention. So you need to be capacity built to be able to explain why are we giving this intervention. Considering in most of these cases, no diagnosis is done. All is done is we're giving a mass drug administration to this community to ensure that they don't get infected. So you need to be able to have the facts back why you need to do this intervention in the community. Then there's an aspect of training around now the digital tool, where we know in this case, we are bringing a digital tool to be able to help the improve efficiency. So there's an aspect of training around that. And of course, the critical part of any campaign is the delivery itself, whereby our healthcare workers need to go to the ground and be able to actually now do the administration of this particular intervention. If it's the case of the bilharzia, they have to give these tablets called praziquantel, whereby you have to go to a household or in a market and be able to give this particular intervention to the community or the population. And then, of course, there's an aspect of payments. As we know, campaigns are done in a time-bound period. So there's an aspect of payments to just motivate our healthcare workers who are now not doing their normal day-to-day jobs to be able to create time to be able to do this intervention in the community. And most importantly, of course, monitoring and response is very key. Without visibility on what's happening on the ground, it's really difficult to confirm, are we hitting the coverage that we need? Because most campaigns, like for NTDs, they run within 5 to 7 days. So you need to ensure that by day 2 or day 3, you already see, are we getting the numbers that we're targeting? And if you're not, do we need to do further site supervision to ensure that we are getting these numbers? Because most of these drugs are donations also get from WHO. So you need to be able to account for all these medication. Next. So for the journey now for us when we got in is now we had this vision of what we needed to do and what the various use cases for the campaigns are. So coming into Kenya, which we know is a very rich country in terms of the digital capacity, we know in Kenya there's a lot of innovation around tech. So for us as CHI, we adopted one simple rule whereby we always avoid recreating or reinventing the wheel. So when we got into the picture, we actually we need to do a bit of a landscape assessment just to understand what is the current situation in terms of, is there any work being done around campaigns to begin with, or is there any work being done around interventions at the community level? And it is through this landscape analysis that we're able to actually engage that time the Directorate for Digital Health, who now are able to let us know that, yes, in Kenya already there's some work being done around community health in line with the community health strategy that was launched in 2020. And part of that meant that there's a standardization of how community health services are going to be provided through now the eCHIS. And for us, we saw that as a very good tool that we can be able to actually hop into, because it covered a lot of the many use cases that we're keen on. One, there was an aspect of service delivery, which is a key aspect of campaigns. There's an aspect of commodity management is also very critical, the supervision. Then there's an aspect of enumeration, because this is covering households. Households are being registered and before an intervention is being administered, which means when it comes to monitoring and evaluation, you can actually be able to pinpoint and actually ascertain that if indeed my coverage is 90%, I can actually account who are these persons who actually got medication. Unlike the paper-based forms, we know we deal with a lot of summary numbers, which someone can easily just sit under a tree and be able to actually come up with numbers. So that's what made us now think of how then we can use eCHIS to be able to deliver for us campaigns. And interestingly, as I mentioned, eCHIS is a service delivery tool, but it did not have any campaign-specific features. So that is a partner through the Division of Community Health Services. We're able to now be linked together with the technology partners led by MEDIC. And here what I can say is a critical piece is there are many collaborative effort where we know we had many partners. We have MEDIC, Living Goods, Loala, Posh IT, IntelliSoft. All these technology partners have played a very key role in ensuring the success of the eCHIS infrastructure and the setup. So through that, we're able to have a consultative forums, we're able to do the design of actually mapping the workflow. How should a campaign be administered? How, when a CHP gets into a household, what is the process that they need to follow to ensure that they are able to administer these services? So the design was done, the development of the system was done, and we were able to culminate in 2024 now doing the first pilot in Kakamega County, where we were able to target 2 wards to be able to just see how will this be done, and we were able to compare now this with the normal paper-based forms. So with the 2 wards were in Kakamega, Chekalini, and Bunyala Central, where we are targeting a total of 110 CHPs and 7 supervisors. And part of the survey was we were able to do a bit of survey with the various users to just understand the usability of the system, what was their view around using eCHIS for campaign delivery, and the reviews are very positive and favorable. 92% of the users exhibiting confidence in using of eCHIS because one, there's the convenience in terms of how you're able to do the work. As long as you have your household members registered, it's a very smooth process to be able to do administration. And also we're able to do something called the system usability score, where we've got a score of around 71.6, which showcases that overall acceptability of the tool to be able to be used for campaigns. And this formed a very big part for us in the sense that there are still issues that of course come up with any new innovation around things around connectivity issues and things around phone batteries, because one of the key interventions that also we're trying to do with campaigns is part of the data use is using the GIS features to be able to now map household mapping, so that you can know once an intervention has been given, can you be able to see on a map, for example, the area that have actually been missed out on, so that by the time you're doing the next delivery of campaigns, that area can also be reached. So this was very good, and it also informed now a lot of work and scale up into 2025. Next. Whereby now in 2025, as we speak, we've been able to also add additional use cases. For example, the malaria team has been able to come on board, and we've been able to do the similar campaign for seasonal malaria chemotherapy. And in fact, we're just from a campaign that ended last on Tuesday for the SMC, the second cycle. And this shows now the capability that eCHIS is able to do. And this has also opened doors for us again in more features around digitizing. So this year, we're also keen on adding other things around digital payments, which again will be riding off the existing work that has been done on the core eCHIS. And of course, a very critical part for any campaign process is the planning piece, where we are very keen to also now do digital micro planning to help the teams now with the rich data that we're having from the household numbers. Can we be able to now actually help programs plan for an intervention that this is the area you're going, this is the population, and so that you can be able to have better estimates for the numbers. So as you can see, there's a campaign calendar for what is happening, the series of campaigns planned between now and December and into 2026 that shows there's an appetite for this. And just to conclude before we get into the demo, next, you can see some of the use cases that have been modeled within eCHIS and the service delivery, of course. You can see there's a service delivery for the campaign where you can be able to give the medication to the households. Then, of course, there are other things associated with service delivery around medication decline, reporting of the adverse events. So that has something that has also been documented actively within eCHIS. Next, we've also been able to map some more workflows around commodity management, which is very critical in any intervention, again, from the commodity supply, what has been utilized, and of course, any returns back to the in the supply chain network. So this also helps us to be able to account to our donors, especially WHO, are very keen on confirming as you're giving medication, are we also accounting for the drugs that you're using on the ground? And finally, of course, the supervision bit is very critical. Next, which is also something that has been done actively within eCHIS, and this is also very critical when you're doing supervision on the ground with the various CHPs as the campaign is happening and even the post-campaign. So in a nutshell, that's what we've been able to do, and I will now just transition to my colleague to now give you the gist of how it actually looks within the application itself, eCHIS.
Thank you, Anthony, and thank you, team, for that comprehensive overview of the use cases. Taking from where team had left, we didn't reinvent the wheel. we leveraged on what exactly is existing on eCHIS. And as you can see on the People's tab, this is where the CHP can be in a position to confirm the balance at hand on the commodities that they have. So what we did, we added the campaign commodities. So as a disclaimer to put across is we've currently modeled 3 campaigns on the NTD. NTD is neglected tropical diseases. So there we have 3 campaigns. The first one is the soil-transmitted helminths, and we normally use mebendazole and albendazole, as you can see here, the one highlighted. And also we have another campaign for schistosomiasis where you normally use praziquantel, and this we use schistosomiasis where you use praziquantel. And also we have another one for trachoma. We normally use the tetracycline eye ointment and then the azithromycin tablets. So this is what we added as far as commodities for the campaigns are concerned. And on my left, where we have now the CHP area, this is where now they find their households. And in this case, we leverage on one household for this demo. So when a CHP visits a household, in this case, assuming it is James, they can be in a position to see the profile and that particular person. And then once they're in that particular household, they can be in a position to select the person that they want to administer the campaign to. So for example, in our case, if we select somebody like Jacinta here, under the Jacinta profile, you can be in a position to see the campaign treatment card. This is where a quick overview of the campaign treatment that they have received or not received. So currently you can see for schistosomiasis treatment, they have not received anything. For trachoma, and the same goes for the soil-transmitted helminths. So as an action, the CHP, once they have selected the individual they want to administer the treatment, there's this action button here where it highlights all the services that this particular person can receive. And what we added or modeled was the NTD campaign service form, as you can see here. So once they open, they now can be in a position to go through the whole workflow. Allow me to mention that this workflow is divided into 3 major components. The first one is on the eligibility criterion, whereby SHP should not administer drugs to anybody who is sick. So this is the first question here: is this person very sick? If the CHP confirms that they are very sick, they are required to use the assessment service and to refer this person to the health facility. But if the answer is an A, then they can be in a position to proceed to the next section, where they are required to select which campaign treatment they are offering for this particular person. So just like I alluded earlier, for the neglected tropical diseases, we are currently having 3 main or principal MDAs that are being conducted in Kenya. So for this demo, allow me to use the soil-transmitted helminths. So once the CHP selects that, then the next thing is we have this placeholder information directive that they need to sensitize this person on the campaign treatment. This is where health education is given. Then the next question, the CHP needs to confirm whether this particular person has received this particular treatment within the last 2 weeks. So anybody who has received treatment for any of the 3 treatment is not eligible to receive another dosage. So in this case, when the CHP selects no, then they are prompted to the next question, with that is seeking now for the consent. As you're all aware, medication is not given to individuals without them consenting. So in this case, for example, if this person does not give consent, then the CHP is prompted to also fill out the reasons for not taking medication or for denying consent for that treatment. So in a case scenario whereby this has been filled and this form has been submitted, then the supervisor, who happens to be the chair, will receive a task notifying them that this particular person has declined medication and has been reported by for example, CHPX. But in our ideal case, let's assume, let's work with a person that is not sick and who has given consent. So if that is the case, then the next section is on the treatment part. So this section confirms or seeks to confirm with the CHP which drug do they have at that particular moment of administering the treatment. So depending on the treatment, for example, if it was albendazole, and depending on the age, so age in this particular workflow acts as the principal metrics that either excludes or allows clients to receive medication. So in this case, this particular person was above 5 years, so that's why there is a leeway for 1 tablet of albendazole, and also the same would work for mebendazole. And then the CHP is given instruction on how to also guide the person receiving. They need to instruct this person to chew the tablet, encourage them to take the medicine, and also address any form of fear or concern that they may be having. And then the next prompt is to also confirm whether this particular person has swallowed or the drug. And if it is a yes, then they are prompted to also indicate the number of tablets they have given. And if it is a no, then we are also very keen to know the reasons for not swallowing, and also as part of education, health education guideline, repeat dose is only to be administered once. And also in this case here, as you can see, the CHP is required to also confirm the total number of tablets that this person has received, including all the wastages. So in an ideal setting for mebendazole, when we are administering, we do not majorly have issues to do with nausea and vomiting. So in this case, it's only one. If, for example, SHP gives or maybe inputs a different number, there is that rule there that confirms that tablet should only be one. And then the next, now after filling the treatment part, clicking next, it now ushers the CHP now to the summary page. This is where now they confirm the person's details, the services they have received, and also any other instruction that needs to be there. So once this has been submitted, this particular person will be recorded as an individual that has already been treated. Before wrapping this particular part, allow me also to talk on the performance. We also married and modeled the in-app analytics for campaigns to what is already existing. So as you can see, we have the reporting ages for soil-transmitted helminths, where we treat with mebendazole. So the reporting ages is between 1 to 4 years, 5 to 14, and 15 and above, and the same goes for albendazole as well. We also have the reporting ages for schistosomiasis, where we normally start 2 to 5 years for cases where we have pediatric praziquantel, and then 5 to 14 years where we normally have and treat with the normal praziquantel that we normally receive from the donors, and also 15 and above. And also another thing, we are also very keen to track people or persons that have experienced adverse events following administration of drugs or the particular drugs. And also lastly, on individuals who have declined medication. So allow me to share now the part for just a sec.
Yeah, Dennis, you can do that in a minute because time is up.
Yes. So we did a pilot, the first pilot on this particular campaign service, and these were the data for Kakamega, which happens to be one county, and we did that in 2 wards. So our key interest was to get the target population, the treated population as well, and also the treatment coverage. As you can see, we had the 70.4%, which was really a win, owing to the fact that this was the first time that this was being done. And also for schistosomiasis, we had a 65.9%. So that was on the treatment, the treatment coverage. We also had visibility on the commodity part. And also the last part, which really made a lot of sense, was the summary table for the performance track. And as you can see, you could be in a position to toggle this between which particular CHP did well and them that were struggling, and that would warrant for any spot check supervision where needed. So that's all. Done, Anthony. Thank you.
All right. Thanks, Dennis and team. I'm not sure if anyone has any question just to share with the team. I can also see Dixon was able to join. Would you take just a minute just to share your thoughts and experience on campaigns?
Oh, thank you very much for organizing this presentation, and also thank you very much for giving me this opportunity just to explain my experience and the experience of the ministry and the user as the main users of this tool in improving our campaigns. Now, first of all, let me introduce myself. My name is Dixon Kioko from the Ministry of Health. I'm the Monitoring and Evaluation Manager. So we started this journey of digitization in 2024, whereby we digitize our campaigns with the pilot areas. This is in Western region. And the tool is now assisting us treating the communities in the areas that we are doing our MDAs. So we digitize all our the campaign module into eCHIS. eCHIS is the community electronic community health system, which is mainly used by community health promoters. And the community health promoters are the key healthcare workers that work at the community level. So we were able to digitize all our tools into the eCHIS, and right now is what we are using for our MDAs in at least 12 counties, 12 wards in Western region. So we are also looking at cascading it to other areas because it will really save us lots of resources in terms of payment to the CDDs, because we expect this to be a continuous module to be used for treatment. It has also assisted us in ensuring we are able to account for our commodities, which was something that was challenging when we do our campaign. So we are able to get our data for our commodities, because we know when what has been distributed to the CHPs, we know what they are going to return back to us, and through that we are able to account. So basically, it has really improved our MDS. Then there are things that also we are able to monitor the performance of the CDDs, the community promoters when they are treating, because the data that we get is live, and we are able to get feedback on a daily basis from our supervisors, because whatever is fed into the tool by the CDDs or the community promoters doing treatment, we can be able to view it and be able to monitor the performance of the MDA. So these are tools that has really supported the whole program in general. So thank you very much. Unless there's any question which I can answer, that's basically what we are doing with eCHIS and the digitization of our campaigns. Thank you.